Dear own distinguished guests and colleagues, first of all, I would like to thank Dr. Jun Hui, Director of Department of Sleep Medicine of the First People Hospital of Yunnan Province. I also would like to thank the organizing committee, especially Dr. Pan Han and Dr. Yuan Chen Kui. And I'm very sorry not being with you in Yunnan for this congress due to the late coming of my visa. Today, I would like to talk about the personalized diagnosis and treatment of obstructive sleep apnea in adults and children. And here is the plan of my presentation. First of all, I would like to give you some information about the obstructive sleep apnea or OSA. And after that, we will discuss about the OSA phenotype based on the pathophysiology. And next, we will uh, change the personalized OSA by clinical phenotype and also the current diagnosis and treatment of OSA. And finally, we will have some remarks about the personalized diagnosis and treatment of OSA. As you know, OSA affects a large portion of the population, more than 15% of men and 5% of women globally. Though some estimate to play this much higher, up to 34% for men and 17% for women. Among children, it ranges between around 0.5 and 10%. And the result of our emphasis study showed that the prevalence of OSA in Vietnamese people is about 8.5%. However, the prevalence of OSA is very high in some specific populations. For instance, more than 60% of patients with transient ischemic attacks or stroke also have OSA. Those with coronary disease, atrial fibrillation, and diabetes. So high prevalence, more than 60%. Among patients with refractory hypertension, it's about 70%. And for patients with asthma COPD or asthma COPD overlap, the prevalence of OSA is still high, more than 35%. And globally, currently we have about nearly 1 billion people with OSA worldwide. And these figures show the estimated prevalence of OSA in different countries. And on your left, we have 10 countries with high prevalence of OSA in the United States, in France, Germany, Russia, Japan, and also in Asia, we have China, we have Pakistan, India. And so we can say that OSA is more than snoring because it's a serious disorder that contributes to cardiovascular diseases, metabolic syndrome, and significant daytime fatigue. It negatively affects productivity and quality of life. Importantly, it also leads to the traffic and occupational accidents that we cannot afford to overlook it. And why personalized diagnosis and treatment of OSA? Because you know very well that traditional methods of treating OSA often apply a one-size-fits-all approach, but we know that the OSA is a heterogeneous disease. Then personalized medicine take into account individual horizon, phenotype, structure, age, comorbidities, and lead to the better patient's outcome. So we can say that the phenotyping is the backbone of personalization, understanding which type of OSA the patient have based on their symptom and physiological traits enable us to tailor the treatment identity and fundamental shift in our approach. As you know, the current concept of OSA phenotypes has been mainly based on its pathophysiological features and classified as collapsibility. It means the airway vulnerability, low arousal threshold, high loop gain, and poor muscular responsiveness. But it's not helpful for diagnosis and treatment in clinical practice due to lack of the consideration of age, craniofacial structure, causal factor, and comorbidities. So it is necessary to have OSA phenotypic approaches based on the diagnosis and treatment strategy classified by clinical feature as we mentioned above. And firstly, collapsibility. As you know, airway collapsibility is central to OSA. A highly collapsible pharyngeal wall often leads to the severe apnea and require the targeted treatment like positional therapy or CPAP. Therefore, understanding this trait is foundational. And this figure show you the effects of decreasing in downstream pressure on your left and upstream pressure on your right on the collapsibility of laryngeal areas explained by the Starling resistor model. And these figures show you how the upstream and downstream pressure change can affect the collapsibility. And this anatomical insight help us predict who will respond well to non-invasive treatment like CPAP or who may need surgical intervention. And here, four key phenotypes that cause OSA within low arousal threshold with high loop gain, poor muscle responsiveness, and all of that can induce OSA. And for low arousal threshold, as you know, the effect of low arousal threshold to prevent the progression of deeper and more stable state of sleep and to reduce the PCO2 and subsequent reduction in respiratory drive. And patients with low arousal threshold easily awaken during sleep. This disrupts sleep cycle and lead to sleep fragmentation. However, in patients with high thresholds might not awake during the dangerous desaturation event. So the achieving a balance is key for the treatment. And now high loop gain. As you know, loop gains refers to the sensitivity of the ventilatory control system. High loop gain creates unstable breathing and large fluctuation in airflow. The patients often benefit from therapy that reduce respiratory overshoot or override. However, SSE low loop gain may result in sustained hypoventilation, induce hypoxia, hypercapnia, which we can see very often in subjects with obesity hypoventilation syndrome. And for poor muscular response, patients with poor muscular responsiveness often cannot maintain open airway during sleep. This is especially true during REM sleep. And, For poor muscular responsiveness, we have some contributing factors including macroglosia, obesity, and flushship. And so the recognition of this phenotype allows us to target the therapy. Therefore, the personalization of approaches to diagnosis and treatment of OSA is necessary to improve the patient's outcome. Personalized OSA is a new strategical approach because the old method did not effectively manage all the crucial issues in diagnosis and treatment of OSA patients. And so far, patients with start with the general approach with the symptom of OSA, with the at-work scale, stop pain, and do the PHG polygraphy as the sleep lab at home. After that, we have the OSA personalized approaches based on the pathophysiology, anthropometry, pathogenesis, or clinical phenotype. Especially, we should focus on age group. For children with OSA, for adults with OSA, or elderly people with OSA, we have different strategical approaches. Then we should look at comorbidities with OSA, allergy genetics, and OSA. All those are obstructive lung disease and OSA. Those are cardiovascular disease and OSA, and diabetes type 2. And we have comorbid insomnia and OSA. And finally, those are Down syndrome and OSA. And after that, we personalize the therapy and follow-up, and personalize also the outcome and the long-term follow-up. It's very, very important. As you know, in children, there are four main causes of OSA: obesity, adenocarcinoma, hypertrophy, abnormalities of cardiovascular structure, as you can see here in the picture, and neuromuscular dysfunction. The structural cardiovascular abnormalities are common in children with hereditary syndromes, such as Cruzon, Pierre-Robin, Amber, Stricker, Hodler, and some other cardiovascular abnormality that cause a short anterior and posterior afferent spay also increases the risk of OSA, such as chin hypoplasia, small chin and large jaw, or myfacial hypoplasia. And last year we published the review on the phenotype in pediatric OSA. It's a very, very interesting topic. And in this review, we classify pediatric phenotype with OSA into 5 different groups. Firstly, the POPWA, pediatric OSA phenotype with upper airway diseases such as allergy rhinitis or tonsillar hypertrophy. And after that, we have PubNet, pediatric OSA phenotype with neuromuscular diseases. Then PubOp, pediatric OSA phenotype with obesity. And finally, PubK, pediatric OSA phenotype with cardiovascular abnormalities. And between them, we also have MPOP, the mixed pediatric OSA phenotype between 4 different groups. Then, based on the nighttime symptoms of the children, such as the snoring, bruxism, restless sleep, and malbreathing, awake due to choking or gasping, associated with daytime symptoms related to learning problems, attention deficit behavior problem, ADHD like fatigue, headache, etc. And after that, we justifies the pediatric OSA phenotype at the 5 different phenotypes, and based on it, we have the personalized treatment of OSA, such as we have the weight loss for children with obesity, we have the treatment with local intranasal corticosteroids. For those with allergic rhinitis, we can do the tonsillectomy. For those with the adenotonsillar hypertrophy, and after that, some few patients of some few children we have the CPAP treatment if needed. And for our say in adults and elderly people, as you know, aging is associated with increase in pharyngeal collapsibility and in pharyngeal resistance during sleep, and is independent of BMI and gender. And so a decrease in the activity of the dilator muscle of the pharynx by the loss of tissue elasticity may contribute to pharyngeal collapse. And so the response of the genital or closest muscle to negative intrapharyngeal pressure during sleep is also reduced in elderly subjects. And for older women, the decreased level of sex hormone partly responsible for the increase of the collapsibility of the posterior oropharyngeal areas. And this figure shows you the adults with OSA with cardiofacial abnormalities. And so with simply the cephalometric X-ray or cone beam CT, you can measure the cellular nation A or cellular nation B less than 75% is a criteria for interventions. And now for OSA subjects with comorbidities. Firstly, for those with allergic rhinitis or AROSA, the mechanism of OSA related to pharynx collapse due to the increase of upstream and downstream pressure and resistance as shown in this figure. And so, and when we have the blocked nose, we can see the collapse of soft tissue due to the increase of critical pressure and it induces OSA. And now, when OSA coexists with asthma, so COPD we refer is the onset of obstructive lung disease in OSA. This overlap significantly complicates treatment and require a dual approach to both pulmonary disease for asthma, for COPD, and for sleep disorder for such as OSA. And the figures are very, very interesting. On your left, you can see here, subjects with asthma can induce the instability of breath is due to the change in chemosensitivities and inversely obstructive sleep apnea also induced by the intermittent hypoxia imbalance of T2 and T1 induce the airway remodeling and inflammations. And the figure on your right side show that the interaction between COPD and OSA. As you know, COPD can have some promoting factors for OSA such as rostral fluidship, cigarette smoking, skeletal muscle weakness, and by the use of medications such as corticosteroid. However, in COPD patients have some positive factors for OSA such as though with low BMI, with learned hyperinflations, diminished REM sleep, or the age are some yielded of valid. And recently, we built up the model to care of asthma, COPD, and OSA in outpatient unit called ACOSU. What does it mean, ACOSU? It means that for patients with asthma and COPD, we should screen OSA to know if these patients had OSA by spirometry, by big flow for asthma, for COPD, and after that we do the polygraphy within the Epworth stopper to diagnose the overlap asthma OSA, COPD OSA, or only OSA with the asthma and COPD. Especially for uncontrolled or unstable asthma, COPD, or overlap asthma, COPD, OSA, we should do the polysomnography, we should do the diffusion, pheno, CPET, even the blood eosinophil count. And for patients with cardiovascular diseases, we call the Cappadocia, and we publish the guidelines to guide the clinical doctor to start with the examination to measure the adenotonsillar hypertrophy and to look at the rigid tongue and also the Brodsky scale. And after that, based on the symptoms, snoring, choking, gasping during sleep, associated time sleepiness, and nocturne, we can do the polysomnography or polygraphy. It depends on the comorbidities, chest, hypertension, heart failure, type 2 diabetes, obesity, or coronary disease, etc. And so for those patients, the stopping questionnaire is very useful. So for patients with cardiovascular diseases or Cappadocia, the diagnosis is very simple. If they have cardiovascular diseases and have the, with resistant hypertension, unexplained pulmonary hypertension, AF, we can refer to sleep doctors. And if not, you can start with the OSA screening questionnaires, and after that, you can do the PATs level 1 as sleep lab at home, or if not, we can do PAT level 3, and based on the reason, you can start the treatment. With minor OSA, can measure with PAT, and after that, we do the follow-up. From moderate to severe OSA, we do the first line treatment. It's CPAP. Second line is MAD, weight loss, surgery for those with ENT problem. And with non-diagnosed suboptimal tests, we can, we should redo the PAT follow-up. And last year, Vietnam Society of Sleep Medicine also published a guideline for the diagnosis and treatment of adults with OSA. We also based on the PAT step 1, 2, or 3, and for subjects with suspected symptom of OSA, and after that, based on the result with mild, moderate, or severe OSA, we have different approach treatment. With mild OSA, with prevention, with weight loss, sonotherapy. We should treat the nasal obstruction, myofunctional therapy, and optimal treatment of comorbidities. For those with moderate OSA, we also do the prevention and MAD if have indication, and we can do the ENT interventions, and after that the second line is CPAP. And for suggest with severe OSA, we start with CPAP and second line with MAD. Other treatment if the patient don't have the good adherence with CPAP. So here is the PhD level 1 as my sleep lab, and level 2 sleep apnea testing at home, but we also do at the hotel. Although my patients came from other provinces or cities, I did it at the hotel. For those with without the complication, not complicated, but and also for children can do it at the sleep lab at home. And very recently, the POSZ World Sleep Society published the recommendation for the year of wearable consumer health trackers that monitor sleep. And these recommendations have very important informations for the consumers. It also go over the lineages, it suggests how to distinguish between the fundamental and exploratory method, and also, stay in touch with evolving best practice for users. And this recommendation also guide the researcher how to use the wearable devices to evaluate the sleep qualities, and also for manufacturer. And so we don't have the time to talk it in detail. And for the treatment of OSA, we start with the lifestyle and positional treatment, and we recommend that the patients with OSA and obesity for weight loss, hygienic dietary measures, and for positional treatment, it's very simple and very effective for those with apnea during the sleep at supine positions. And so, we can guide the patients for different positional treatment on the left or right. It depends on the reason of PhD or polygraphy. And after that, CPAP therapy remain the cornerstone treatment for moderate to severe OSA. Is especially effective in reducing daytime sleepiness, improving the quality of life, and decreasing cardiovascular risk for short and long term. Especially the recent publications show that OSA linked to the risk of dementia, especially in large scale population. In UK, it's about 193,000 individuals with OSA. The risk of vascular dementia is about more than 22%. And luckily, the early treatment with CPAP may reduce dementia risk for patients with OSA. And after that, we have surgical options. It includes the tonsillectomy, pharyngoplasty, and more advanced techniques like mandibular advancement, and for children, particularly those with large hypertrophy of tonsil, they may benefit from surgery, tonsillectomy. Here is the reason of our patients in National Hospital of Children in Hanoi, Vietnam, for children with adenotonsillar hypertrophy grade 3 or 4, or measured by scale, we treat with adenotonsillar lectomy, and for those with grade 1 and 2, we treat with anti-glucotriene receptor, and it's very, very efficacious, and we have a good result. Here is a case of our patients with severe OSA treated by endoscopic gallbladder to open the tongue base with recession, and it improves apnea, hypopnea index. And for hypoglossal nerve stimulations, as you know, this novel therapy stimulates the hypoglossal nerve to maintain the airway patencies. It's also an alternative for patients who can tolerate CPAP and have appropriate anatomical indication, as you know very well. However, this treatment is still costly. And then the treatment with mandibular advancement device, MAD, is still indicated for patients with OSA of any severity who are candidates for CPAP therapy but unable to adapt to it. So MAD is an alternative to CPAP. And for patients with mild to moderate OSA, minor symptoms are troublesome snoring and no indication for CPAP or any other treatment, we can prescribe the MAD. And for myofunctional therapy, this therapy focus on the strengthening the oropharyngeal muscle through targeted exercise. You know, here, the application we build up to train the patient with this objective. And recent evidence supports SJU in reducing AHI and improving oxygen saturation. So at the low cost, a simple option, particularly if it's in combination with other therapy, especially for young people. And recently, some study published the result of malfunctional therapy with the use of didgeridoo. It's very well known in Australia. Luckily, in Vietnam recently, I've found out a club of people they use the didgeridoo for as a musical instruments, and so I think this kind of technique is good to train the muscle of the laryngopharyngeal areas. And interestingly, the use of train of malfunctional therapy for subject with CPAP treatment can reduce the pressure, and so we can combine the treatment with CPAP with the myofunctional therapy. And finally, how about the medical treatment? So the medical treatment, we know very well the use of anticholinergics such as arosiputinine and non-adrenergic reuptake inhibitors, such as atomoxetine, to reduce the apnea-hypopnea index in some trials, but these drugs have many side effects. And recently, the treatment of obesity with disabilities for OSA published in New England Journal of Medicine is very interesting. With the subcutaneous injection of 5, 10, or 15 milligram per week during 52 weeks can improve the apnea-hypopnea index in subjects, without CPAP, and also for those with CPAP, is improve very, very significantly the AHS. This drugs have some side effect, but not the same with placebo. In conclusion, we can state that personalized management of children and adults with OSA based on OSA pathophysiological phenotypes classified as collapsibility, uh, low arousal, and high loop gain, and poor muscular responsiveness is difficult in clinical practice due to the mismechanism in each given patient. So, personalized management of children and adults with OSA based on clinical feature phenotype may have more advantages for diagnosis precision and accurate treatment. Finally, personalized management of children and adults with OSA, and the objective is to improve the treatment effectiveness and to avoid the detrimental consequences of OSA. Thank you for your attention. And I would like to invite you to attend the Vietnam Society of Sleep Medicine Congress next year in Sabah in 2021, June 2026. Thank you.